Good evening, ladies and gentlemen. It gives me great pleasure tonight to welcome you to our new edition of Circulate, Advancing Patient Care and Thrombosis. We have two excellent speakers today, one from the Emirates and the other from Qatar. We'll be talking about NOACs and their use in different diseases. It gives me great pleasure to present, first of all, my friend, Dr. Mu'taz Al-Qadri, who is currently working as an electrophysiologist in Mediclinic Abu Dhabi and Valiant in Dubai, previously, as you know, in Sheikh Khalifa Medical City and Sheikh Shahpoort Medical City. Dr. Mu'taz has great experience in electrophysiology, and he will talk to us tonight about the dilemma of using NOACs in atrial fibrillation. Welcome, Dr. Mu'taz.
Thank you. Okay, I'm just going to share my screen here. Good evening, everybody, and welcome to this quick session about the dilemmas of the use of NOACs in patients with atrial fibrillation. My name is Mu'taz Al-Qadri. I'm a cardiologist and electrophysiologist practicing in United Arab Emirates. So let's start with some basic facts about atrial fibrillation and anticoagulation. When we treat our patients, we always want to give them the best possible outcome. This is a given. This is part of what we do as physicians. The ideal drug will have 100% efficacy and 0% risk. This would be the drug that we all want to have. However, no such drug exists. We always have to strike compromises. Deciding between the NOACs in atrial fibrillation is often a balance between the risk of stroke or protecting the patients from stroke and between the risk of bleeding. There's no medication that will, tick all the boxes. We have to know what our priorities are. I mean, are we trying to protect the patient predominantly from stroke and then we have to go for a certain NOAC? Or are we trying to protect him predominantly from bleeding in a higher risk bleeding patient? Or are we trying to find somewhere in between a drug that can have the balance between protection from stroke and the risk of bleeding as well? Whilst all NOACs are in a way or another better than warfarin in something, there are differences that exist between them. So let's review the data that we have so far. So we know that comparing warfarin to placebo or to aspirin, warfarin is significantly better, 64% reduction in the risk of stroke. And we know that if we compare NOACs to warfarin, there's probably another sort of 20% relative risk reduction. Now, if you add all of these together in terms of protecting patients from stroke, the NOACs versus control, you get about 71% reduction in the risk of stroke. So this is very clear benefit. And the clear benefit is translated into an all-cause mortality, but that's predominantly also, a huge reduction in hemorrhagic strokes. And these are the main benefits that we have in terms of NOACs. Now, if we look at this meta-analysis from Christian Ruff, I think this was in 2015, you'll find all of the NOACs compared to each other in terms of the risk of stroke and systemic embolism versus major bleeding. And it's a difficult slide to look at because really when I'm telling you, okay, can you find me the best NOAC? It's difficult to tell from this slide. What I find more useful is to actually stratify them based on which one is better for stroke, which one is better for bleeding. And if we stratify them, you'll find that the best agent for protecting from stroke and systemic embolism is the Bigatron, 150 milligrams twice a day, and followed by a Pixaban, 5 milligrams twice a day. These were the only two that were statistically significant in reducing the risk of stroke and systemic embolism in all these randomized controlled trials. Now, we also have to balance this into the risk of bleeding. So we find that Edoxaban 30 milligrams is the safest in terms of major bleeding, followed by a Pixaban 5 milligrams, the Bigatron 110, and the Edoxaban 60. So these were the four that were statistically better than warfarin in terms of that. The problem is, if you look at the Edoxaban 30, which is the safest one, it really is a very poor protector against stroke. And equally, if you look at the Bigatron 150, it actually is no better than warfarin in terms of the risk of bleeding. So compared to warfarin, it's almost as good as warfarin. The only one that actually ticks some nice boxes, which means that it's safer than warfarin in terms of bleeding and better than warfarin in terms of stroke protection, is a Pixaban, which maybe it doesn't protect as highly as the Bigatron, but it certainly doesn't cause as much GI bleeds as the Bigatron. So when we're trying to deal with patients with AF and anticoagulation, we're trying to assess many things, and there are many dilemmas when we're dealing with them. So for one example, the risk of bleeding is a very big risk that we have. So if we find that, if you look at most of these medications, you will find that they're hovering a little bit to the right of the line there, but they're not equal. So the dabigatran 110 is safer than warfarin. Pixaban 5 milligrams is safer than warfarin, but the dabigatran 150 and rivaroxaban were no better than warfarin. So there's a bit of a difference in between them. This is for whole risk of major bleeding. That's big GI bleeds, intracranial hemorrhages, and things like that. The big advantage that we have with NOACs is that, obviously, if you look into the subcategories of these major bleedings, you will find that hemorrhagic strokes are consistently lower than warfarin. It's about half of the risk of hemorrhagic strokes compared to warfarin. But that is at the expense of higher risk of GI bleeds. Now, if you look at the intracranial hemorrhages, we will find that this is more or less a class effect. All of them are better than warfarin in terms of reducing the risk of intracranial hemorrhage. However, if we look at GI bleeds, they're not equal. So if we look at dabigatran 110, it's more or less similar to warfarin. Dabigatran 150 and rivaroxaban, it's higher than warfarin. This is statistically significant. Pixaban is a tiny bit better than warfarin in terms of the risk of GI bleeding. So if you're worried about GI bleeding, you're talking either Pixaban or the dabigatran 110, with the Pixaban showing a slightly more benefit in this category, although it doesn't reach statistical significance. This is a nice study which looked, okay, well, the randomized control trial, these are the data with them, okay? For dabigatran, it's more or less the same in terms of GI bleeds. Rivaroxaban seems to be slightly worse. Pixaban is just a tiny bit better, and edoxaban is about the same. And then they looked into the real life data, and they found that dabigatran followed the same trend, so it's more or less the same. Rivaroxaban was equally more or less the same, or slightly worse than warfarin. But if you look at the Pixaban, the real life data was significantly better than its landmark trial, which is a very important thing, because ultimately we use these medications in real life, not just in the randomized controlled trials, which are highly controlled settings. If you look at the GI safety profile for NOACs in elderly patients, so the picture becomes a little bit more difficult because these patients are more likely to bleed. But if you look here, you will find that Pixaban is slightly better than warfarin. There's a trend towards being better than warfarin, but the dabigatran and edoxaban and the rivaroxaban were not necessarily the same. So the best one here was Pixaban, followed maybe with a bit of trend with edoxaban, but the others were slightly worse although none of them reached statistical significance. And because of that, the ESC guidelines in 2006 said in patients with high risk of GI bleeding, a vitamin K antagonist or another NOAC preparation should be preferred over dabigatran, rivaroxaban, or edoxaban. So basically, they haven't named Pixaban, but they've excluded all of the others. So if you have somebody with a GI bleeding, your better safety option would be with going with Pixaban in terms of GI bleeds. And later on, what you have to decide in a patient who had a recent bleeding event, you need to address the underlying cause. So if there's a polyp or an ulcer, you need to treat them, and then reintroduce the NOAC with a multidisciplinary team decision or a discussion about this. And then, you should try to use a NOAC or vitamin K antagonist in the patients who had GI bleed to try and minimize the risk of further bleeding. You always have to remember that the dabigatran tends to cause a bit of dyspepsia in patients. And when you're trying to restart or initiate or continuing a NOAC, there are certain things that makes it a bit more difficult. Things like having multiple angiodysplasias in the GI tract, or the patients with significantly older age. And at some point, you need to take a decision. If the patient is not suitable for it, then you need to consider either no anticoagulation or a left atrial appendage closure, versus saying I would reinitiate it with any oral anticoagulant, but feasibly with one, or better with one that has lower risk of GI bleeding. The second dilemma that we have with NOACs is patients who are elderly. So there are difficulties in anticoagulation in the elderly. One of them is they tend to have lower BMI and they're frail old patients. The second thing is the altered composition of muscle and fat. And this has an effect on when you're calculating GFR and creatinine and things like that. There's a high prevalence of renal impairment, and most of these NOACs, to a certain extent, are excreted by the kidney. So renal impairment tends to affect their function or toxicity quite a lot. There's a lot of drug interactions. These patients are normally on a lot of medications, and these medications tend to interact with each other. And most of the studies did not have a lot of randomized patients in that sort of age group. So if we look at patients, it's not particularly a very nice category to be in. So if you look at these bars, so less than 65 in yellow, 65 to 74 in green, and red is 75 and above, you will find that your risk of stroke and ischemic events increases with age. Your risk of ischemic stroke increases with age. Your risk of major bleeding goes up with age, and your risk of intracranial hemorrhage goes up with age. So all of the potential complications of atrial fibrillation or anticoagulation are significantly higher for similar patients but different ages. Now, in the meta-analysis that looked into the landmark trials of NOACs, they looked into the patient below the age of 75 and a patient above the age of 75, and NOACs were significantly better than warfarin in both categories. In fact, if you look in Aristotle, which is the Pixaban study, they stratified them again based on age, and you will find that the risk of stroke and systemic embolism, the effect was very clear at the higher ages. So these patients don't lose the benefit from the medication as the age progresses. And equally, the risk of bleeding seems to even get better as the patients get older compared to warfarin. So it doesn't necessarily mean that apixaban in older patient is safer than apixaban in younger patient. What you're saying here is apixaban in older patient is safer than warfarin in older patients. Okay, these patients we're going to anticoagulate them, but we need to anticoagulate them with the safer option. So what does the randomized controlled data show in patients above the age of 75? So if we look at the medications, so this is warfarin, the Dabigatran 110, the Dabigatran 150, rivaroxaban, apixaban 5, and edoxaban, you will find that the risk of stroke and systemic embolism is best protection is with the Dabigatran 150. We know that, followed quite closely with apixaban 5 milligrams BID. If we look at the risk of GI or risk of major bleeding, you will find that apixaban and edoxaban were the only ones that were basically statistically significant in terms of protecting from major bleeding. If we look at GI bleeds, apixaban is the only one was comparable to warfarin. All the others were worse than warfarin in terms of protection from GI bleeds. And if we look at intracranial hemorrhage, pretty much most of them were better than warfarin, maybe with the exception of rivaroxaban, but all the others were better than warfarin. And this is specifically for the patients above the age of 75, which is very important. Now, it's the same data, but they looked at it slightly differently. So what they said is that if you have somebody who had a GI bleed or who lost more than 2 grams of hemoglobin, this will be considered as GI bleed, but the patient will go in, get a couple of units of blood, have an endoscopy, and go home. Versus somebody who comes in with an intracranial hemorrhage, and this is a devastating complication. So although both of them would count as a major bleeding, but they're not equal in themselves. So what they've done with this analysis is that they've said, actually, we will give the intracranial bleeding more weight. So we'll give it 1.5 weight or 2 weight. So every intracranial bleed here will count as 2 major bleeding from another compared to other GI bleeds. And what they found on it, when you analyze it like this, is that you will find that the best one in terms of safety is actually apixaban, followed by edoxaban. But compared to the others, they're very far away from each other. Apixaban is by a mile ahead of the others. And the benefit is even more obvious when you are actually looking into this with a double weighting for the intracranial bleeds. This is some from Aristophanes, which is a real-life data study, but this is the old and frail part of the study. So if you look at the apixaban, this is warfarin, this is stroke, this is bleeding. So it's better than warfarin in terms of stroke, better than warfarin in terms of bleeding. If you look at the Dabigatran, you will see that in terms of stroke prevention, it's about the same. In terms of bleeding, it's slightly better than warfarin. In terms of the rivaroxaban, they're more or less the same, but the risk of bleeding is actually higher in the rivaroxaban group. So this is the biggest real world data study that is so far. It's almost like 300,000 patients. The final dilemma we have is the patients with renal disease. So chronic kidney disease increases your risk of thrombosis in AF patients who are not taking warfarin. So if your patient has AF and not taking warfarin, as the GFR goes down, the risk of thrombotic events goes up significantly. Now, even in patients who are taking warfarin, the risk of stroke goes higher as the renal function gets worse. So does the risk of bleeding. So the risk of bleeding also gets worse as the renal function gets worse, reaching dialysis. And this is from the Danish National Registry, more than 130,000 patients. The problem with warfarin is that as your GFR goes down further and further, your time in therapeutic range, which is the green, which is what we want, is really becomes like almost 40% compared to above 60% when your GFR is above 60. So the INR becomes very labile when your GFR goes down. Now, if we look at the meta-analysis for NOACs in patients who have got renal impairment and elderly, you will find that up to the age of 80, up to creatinine 50, less than 50, they actually do quite well. So with a creatinine with a GFR of above 80, it's equivalent to warfarin. But the lower GFRs or creatinine clearance, they tend to do better. So the benefit is actually quite good in patients who have renal impairment with NOACs. If we look at individual ones, you will find as the GFR goes down with the Bigatran 150, your stroke prevention is maintained. However, your risk of bleeding starts to increase, becomes similar to warfarin when the GFR is low. The 110 shows a similar trend as well, with as the GFR goes down, your risk of bleeding starts to go up. Doesn't get worse than warfarin, but still considerably higher. Rivaroxaban seems to be sort of on the midline there. What you can see with Pixaban is that although it protects when the GFR is less than 50 from stroke, the benefit in terms of major bleeding compared to warfarin actually gets better when the lower GFR. So, and if you look at it as a continuum, I will show it to you in a minute. So if you compare all of them together, look at the group with a GFR of less than 50, in terms of stroke or systemic embolism, they're all pretty much okay. Maybe the Bigatran is better. But in terms of the risk of major bleeding, the only one which is really way ahead of the others is the Pixaban, followed by the Edoxaban. But Pixaban is very clearly ahead of the others in this one. Now, the problem, if you compare, for example, Pixaban with warfarin, is that as the GFR keeps on going down, your risk of bleeding and stroke starts to go up in both groups, but it seems to go higher in the warfarin group compared to the Pixaban. So it's not like, okay, when somebody has, let's say, a GFR of 30, that they are safer than the ones who have got GFR of 120. It's not like that. What it is like is that it's better in terms of safety compared to warfarin. So we are going to have to anticoagulate these patients, but we want to anticoagulate them with something which is safer than warfarin. And the same thing is that this is the elderly patients with a lower GFR. So you can see that the stroke and systemic embolism protection is maintained to below 30, and the major bleeding is also maintained to below 30 of GFR. So to summarize in terms of NOACs and renal problems, so the Bigatran, below 50, you have to start considering lower the doses, and below 30, you're not allowed to use it. Rivaroxaban, 20 milligrams down to 50, and then beyond that to 15 mils, you have to reduce the dose. Edoxaban, 60 to GFR of 50, and then below that should be 30. And the Pixaban is, you can use it, depending on the 2 of the 3 criteria, down to 15 mils per minute in terms of GFR. And as you know, there's an update that you can now use it in dialysis patients, although this is not necessarily endorsed in the Middle East yet. So in summary, NOACs, we know they're better than warfarin. You need to identify your treatment goals. So if you have a young patient who has had a stroke, then you really want the best stroke protection, and maybe you should go for the Bigatran. If you want somebody who's had a GI bleed, then you need to consider something with a lower GI bleed risk, like Pixaban. If you wanted an all-rounder, something that would reduce the risk of GI bleed and protect you from stroke, currently the only one that ticks these 2 boxes is actually Pixaban. Striking between a balance between efficacy and safety is not always an easy option. For most patients, Pixaban offers a very good balance. It is particularly attractive in certain high-risk population like GI bleeds, like the elderly patients, and like patients with renal problems. Try to use a NOAC which you best suits your patient's profile. So you have to individualize the use of these medications. Thank you very much.
Thank you very much, Dr. Mu'taz. We'll be taking your questions at the end of the session. Our next speaker tonight is from Qatar, Dr. Abdel Nasser Azzouki. He is a consultant of internal medicine, Chief of General Internal Medicine in Hamad Medical Corporation. He is also the Program Director of the General Internal Medicine Program. He will talk to us today about Dvte from clinical trials to real practice.
Yes, thank you very much, Dr. Weil, for the kind introduction. In the next 20 minutes or so, or 25 minutes, I will go through the treatment of the Dvte treatments, and we try to take it as a journey from clinical studies and to the real practice and that we are doing in our. So this is my outline. So as I mentioned, I will describe the treatment of the Dvte in acute phase. Also to give a review about the evaluation of the provoked and unprovoked, and also to review the clinical studies and how it will take us to the real world practice that we are doing today. At the end of the presentation, we will also talk about the duration and the extension of the treatment in Dvte patients, and then ended by summary and conclusions. We all know that Dvte is an important and major problems that we see in our hospitalized patients. If you look to the statistic, it occurs in about 1 to 2 per 1,000 persons per year. It has an incidence, it's up to 30% in the hospitalized patients, particularly in the surgical and in acute medicine and cardiology wards. And also Dvte causes death, and one of the major cause of death in the hospital, but also one of the leading cause of preventable death, and therefore the practice of the Dvte prophylaxis, it's one of the benchmark or the indicators, KPI indicators for the any standardized service in all hospitals nowadays. Although 60% of Dvte are asymptomatic, but again, the overall mortality it may goes up to 10%. And when we talk about PE, pulmonary embolism, death can occur in the first few hours in the arriving of the patient to the hospital. And this will carry mortalities up to from 10 to 30%. So it is important disease from both morbidity and mortality. Just to remind you with the triology of a clot, and this is the Virchow and his triad, where the three components of the hypercoagulability, where we see it in patients like in pregnancy, in oral contraceptive pill patients, and in active cancer, and all with those familial or hereditary diseases that can cause thrombosis, like factor V laden or protein C or S deficiency, and also in antiphospholipid syndrome. The other part of the triad is the stasis, where there is people who are bound in the bed, in the long bed rest, hospitalized patients for some diseases, for example, travel for long distance, and both patients with low cardiac output. And the third triad, and when there is endothelial injuries, and we see this in the trauma and prior VTE or DVT, and also in the surgery. If there is one conditions that gives like a low to medium risk, if two conditions are there, then give like medium to high risk. But if the three hypercoagulability stasis and endothelial injuries occur, that will label the patient as high risk. Why we do this? Because when we start, and I mentioned this in the treatment, categorize or stratify the patient according to the risk is very, very important in terms of onset of the treatment and starting of the treatments. We all know about the VTE risk factors. I don't want to mention them all, but one thing that I need to also remind people is the age. So when we admit patients with particularly elderly ages, we need to consider them that age by itself is a risk factors. And this is the data, we know it from the last at least few years ago, that age 65, and it goes with higher incidence of the VTE compared with the younger patients, whether this is when we talk about deep vein thrombosis or when we talk about pulmonary embolism. So what is the treatment that we are, or what are the options that we have for the treatment? We all know that long time in the previous decades, we have the heparin, we have the oral warfarin and dicumarol, and then the low molecular weight heparin and enoxaparin in the 90s, and fondaparinux in the thousands. But to be honest, then nowadays we have maybe medications that the ideal that we want to look for as an anticoagulation, we have oral administration medication like warfarin, but it has also a predictable anticoagulant response. But we need to monitor this medication. We need to wait for a while there to start the onset there, where we need to bridge it with the heparin in the most of the situation. And we have a problem in the rapid reversibility and to availability of the safe antidotes. And of course, it has also major side effects apart from the bleeding itself, and also issues like drug interaction, food interaction, and so on. So therefore, in the last decade, that a new group of medications, namely what we have 4 medications here, at least in Qatar, we have 3 of them in the available in the market and for our patients, the Bigatran, Pixaban, Pixaban, and we don't have yet the Doxaban as a treatment, but these are the 4 medications that we call it direct oral anticoagulations. And if you compare it with the warfarin, it has the advantages that over the warfarin, particularly that's what I mentioned, say that this is some of the problems that in warfarin that we have it in the past. So we don't need to monitor this medication. We don't need to consider much about the food and diet of the patients. And in at least in 2 of these medications, the Pixaban and the Pixaban, we don't need to use or bridge with the heparin or low molecular weight heparin. And it is rapidly therapeutic care and no initial hypercoagulability. It is, and I will show, and we hear it from my colleague in the previous presentation, it is, in terms of the safety, it is more safe than the warfarin, as you heard in the previous presentation, and we are going to talk about it again here. And we have the available reversal agent for this in case of any major event, or especially the major bleeding or so. So we could do reversibility for these medications. Still, there are some drawbacks for this medication. We don't have a good evidence to use it in some of the conditions, like mechanical heart valves, for example. We have some of the conditions with the like antiphospholipid syndrome. We still use the old friend warfarin, waiting for more data to support this. Of course, cost, it was an issue, but I think if you look to the cost benefits in general, if you consider what are the other things like monitoring, clinic visit, and follow-up, and changing the doses, and so on, I think you will balance, and there are studies shows that cost benefits is not only the cost of the medication, but you take the overall benefit of the medication. Here is the, when we talk about site of the action, I think this is the reason why I didn't become a hematologist, but we'll make it like a more easier way how these medications are working. It is both, we have like factor 10A, which is blocked by the rivaroxaban, apixaban, and edoxaban. And we have the thrombin 2, which is blocked by the dabigatran. And by this mechanism, these medications are working as a treatment for VTE. So let us go about taking a comprehensive and simple practical approach to use this medication in case of the VTE. So when we have a patient with VTE, we have to start the initial treatment, and we need to select among some options available. And we will try to use the clinical evidence that we have based on the clinical studies and to translate it to the what practice that we are doing today. I mentioned about the 4 medications that we have available in the market now for this treatment of DOACs for VTE. We divide them into 2 groups. One is the dabigatran and edoxaban. For this medication in acute treatment, we need to bridge with the low molecular weight heparin subcutaneously. And this is usually for 5 days, and then we continue with these 2 medications. On the other hand, if we choose to use the apixaban or rivaroxaban, we don't need to bridge with any low molecular weight heparin. And therefore, we can start from day 1 these medications. And I remind you that all of them, they are oral medications. So this is good, some flexibility for the physician. I think if we are in the acute medicine, for example, we may treat a simple Dvte or even mild pulmonary embolism right away with simple medication, I mean, without an injection, and we may send the patient home with this medication based on the stratification of the risk, and then we follow in the few days of the patient, and we avoid by this. And this is, you can add it to the cost, as I mentioned earlier, if you want to bridge and look for the INR and make sure that the patient in the target or the goal of the treatment before that. And then whenever you choose the selected, then you need to treat it as a treatment. I will mention about the duration, usually in provoked for 3 months. And then if you want to extend, then we will talk at the end of this talk about the extension of the treatment. Here you can see the doses of each medications, the dabigatran 150 milligram BID. We have the dose of 110 milligram BID. It is used usually in the elderly patient above age of 75. We may consider the 110 milligram. And also I will mention about, and also my colleague also in the previous presentation mentioned about the creatinine clearance level, and therefore if the creatinine clearance is less than 50 and above 30, we may use 110 milligram BID instead 150. Edoxaban, we don't have it in at least in our practice here, but the dose is 60 milligram once daily. Apixaban, we start with 5 milligram BID and follow it by the and then we continue the treatment. And if there is any extension, then we may reduce the dose. Rivaroxaban, for 3 weeks, we give it for, and apixaban, we have to start with 10 milligram BID for first day, and then we continue. And then rivaroxaban for 3 weeks, we use 15 milligram BID, and then we continue with 20 milligram once daily, and for the end of the treatments. What is the evidence that we have behind this treatment options? We all know about the studies, the clinical trials that have been mentioned. For the dabigatran, we have the RECOVER and the RECOVER 2. This is basically one for a number of about more than 2,000 patients, and it is double blind and used, as I mentioned, with bridging with warfarin. The dose was 150 milligram twice daily. Edoxaban, it's about 8,000, and it is for 4,000, 3,000 based on the disease. It's Dvte or PE, again double blind, and again with bridge with the heparin. Rivaroxaban, we have Einstein Dvte and Einstein PE, and again it's 3,000 plus and 4,000 plus. And this is studies that is open label rather than it is double blind, and no bridging was used. And as I mentioned, 15 milligram for 3 weeks, followed by 20 milligram once daily. Apixaban amplified study, which is 5,000, more than 5,000 patients divided into Dvte and PE patients. It was double-blind study, no bridging with warfarin, and giving 10 milligram twice daily for 7 days, followed by 5 milligram twice daily for the completion of the treatments. This is the amplified study, which shows that this is the, as I mentioned, randomized double-blind study, and the primary endpoint was to see if there is the efficacy in terms of the evaluate the compared with the warfarin. And this is the study, used a 10 milligram BID followed by 5 milligram BID. The primary endpoint, which is looked to the recurrent VTE or VTE-related death, there was no non-inferiority results here. And you can see here the number of events in the apixaban arm compared with the number of events with enoxaparin or warfarin arm. And the relative risk is about 0.4. So there is a reduction of about 16%. But this is no non-inferiority, and as you can see here, the confidence interval including 1. The secondary endpoint was looking to the measure of bleeding, and here shows the superiority really. So you can see here the relative risk is 0.31, so there is about 69% reduction compared with the warfarin and enoxaparin. And this is giving a relative absolute risk reduction is 1.2%, which is, I think, show clearly here is a superiority compared with the warfarin in terms of the measure of bleeding. Here is the RECOVER-2 trial, looking for the dabigatran again. The primary outcome is the efficacy. Again, you can see here there is no difference compared with the warfarin. And the look to the measure of bleeding, it was no different. But if you look to the clinical relevant non-measure bleeding, it is in favor of using dabigatran. Einstein Dvte study for the rivaroxaban, again for the efficacy is non-inferiority. There is no difference with warfarin, and also for no difference in both measure bleeding and the clinical relevant non-measure bleeding. But in the Einstein pulmonary embolism trial, again, no difference with warfarin in terms of the efficacy as a primary endpoint, but also there is no difference in the clinical relevant non-measure bleeding, but there is in favor of the use of rivaroxaban in terms of the measure bleeding. This is a meta-analysis where it shows all trials in the 4 medications, but mind you that there is no head-to-head study in this comparison, rather than it is used, the data used based on the compared with the warfarin and plotted in a meta-analysis format. And you can see here as a primary endpoint, there is no difference, although that there is a trend to favor of using of DUAC in terms of efficacy. However, this is not cross the one line, so that's no difference. At least there is no non-inferiority compared with warfarin. However, when you look to the measure of bleeding, and you took all the trials together, and this shows clearly this is more safe to use the DUAC, more favor to use the DUAC in terms of the to avoid measure of bleeding. And when you look to the particular studies here, which is studies that make more weight in terms of the measure of bleeding, you can see the Amplify study, we use apixaban, clearly is significantly different, and I mentioned it's considered as a superiority in terms of the more safe and less major bleeding. The second one is the rivaroxaban in Einstein pulmonary embolism, and also the others, although they cross the line, but it's more, all of them, they are more trend toward the favor of DOACs. So in terms of the efficacy, DOAC is comparable to what we used before, but it is the advantage is that we are more safer drug. Mind you again that there is no head-to-head comparison in this. And based on this meta-analysis and these clinical trials, the ACCB guidelines clearly mention that in patients with the VTE, whether patients have DVT or PE and no cancer, and you want to use treatment with anticoagulation, they suggest to use the DOAC as a first choice. And then you have to, among the available medication, it's up to you as a physician to decide, but you have to remember that if you choose to use the Pixaban or Edoxaban, then you need to bridge with 5 days of the low molecular weight heparin or any kind of heparin. But if you want to choose Pixaban or Rivaroxaban, you can start orally right away from the day 1. I mentioned about the comparison with the warfarin in terms of major bleeding, but what is most important is what is the site of the bleeding. And this is, again, the data shows that in all studies that all medications that I mentioned, if you look to the site of treatment of the bleeding as a major bleeding, in case of the Pixaban, so the major bleeding is mainly in the it's significant in favor of the Pixaban if you have intracranial hemorrhage. And if you look to the rivaroxaban, again intracranial hemorrhage. But if you have used a Pixaban, GI bleeding is less, and intracranial hemorrhage also is less, and the other bleedings also are less. So that gives you the consideration when you use if your patient, for example, have peptic ulcer disease or DU, he was using aspirin or whatever, and that's the choice, which is, then there is a risk of GI, then you choose whatever you like. And other patients, maybe they are choosing for the other medication. So that's the details of these trials that gives you also help you in practice. What is your choice as when you come to the treatment of these patients? If you consider that the patients has the primary endpoint is the efficacy and the safety is the other issues, and you plot it in this graph looking to the VTE recurrence in one arm and the bleeding and safety in another arm. And here it comes the Einstein trial, where it goes, it clearly show that there is good in efficacy, but I mean non-inferiority in efficacy. But think about compare with the others in terms of the safety. Here is the Pixaban again. You can see where they plot the trial in this graph, where the efficacy and safety is there, and also the recover trial also for recover and recover 2 trials, and also here you can see the amplify. And if you compare all 4 medications, you can see that probably the Pixaban is have fewer VTE recurrence and fewer bleeding if you compare it with the other medications. Again, mind you that there is no head-to-head or direct comparison among these medications so far in any studies, but these are data which is plotted based on the available information. My colleagues here already mentioned about importance of the renal adjustment in terms of the doses. Here that creatinine clearance is one of the marker that we are following and we are evaluating, and also we have to look at it at the beginning of our medications, and always we have to remember the creatinine clearance. If it is less than 30 in case of the rivaroxaban, then we have to avoid. Pixaban, it can be used, and there are not in our area, but at least there are studies shows even in US studies that even safety of this medication in the patients on dialysis. But we using it because it's the most friendly in case of the renal impairment is there. The Bigatran, you have to avoid it if less than 30, and also edoxaban, we don't have experience with it, but also you have to avoid it if less than creatinine clearance is less than 30. So what is the practice? I mean, we need always to do a risk stratification to assess for in case of the PE, for example, is our patient is at high risk or at not in high risk. And then this is from up to date 2022. And so that's our practice, what we are doing. So when you do the risk stratification for the PE, if you have your patient have low or moderate or high risk, and we have some criteria that we are using, Wells criteria and other criteria that we use and evaluation, including also maybe some also investigation we do. And when we label the patient is at high risk, so we have to start right away anticoagulation before we think about whether we do the diagnostic criteria, because it may take times. And we can readjust ourselves the criteria, the evaluation with diagnosis. But if we have low risk, on the other hand, then we ask ourselves, is the diagnostic evaluation, so CT angio or VQ scan, it will take more than 24 hours? If the answer no, it will not take longer, then we don't need to start with anticoagulation. We just, and if we start it, if the duration will take more than 24 hours. In case of the moderate risk, we'll ask if diagnostic tool that we are going to use take more than 4 hours. If yes, we start anticoagulation. If no, then we do the diagnostic evaluation. And then if PE excluded, then we look for the other causes. And if anticoagulation is started, then we stop the anticoagulation and look for other causes. If PE confirmed, then again, does the clinical severity warranty consideration of thrombolysis, or we just justify? And we have also a clinical evaluation, as we know, to do and to choose whether to continue anticoagulation or to choose other modality of the treatment. This is up to date in 2022, and the practice that we are doing in terms of in case of the PE as a VTE example here. So when we start the treatment, all guidelines now, if we have a provoked, and the new guidelines that if we have a clear provoked VTE, 3 months duration of treatment is enough, compared with what we usually used to use before, 6 months or so. But now 3 months, if there is a clear provoked, especially by surgery or whatever, because as you can see here, the recurrence rate, it will be very, very low. And if we do this treatment, if we have unprovoked, then we have to extend the therapy, and we will talk about the extension of therapy later. There are some situations we don't know, or it is provoked by non-surgical risk factors, especially chronic problems and this multifactors. For example, patient have acute cancer, for example, need to be treated, and then while they is still in the acute phase of cancer, need to be considered that he's at risk for VTE recurrence and development. So that's the 3 categories that we use. And the extended, usually we say indefinite for unprovoked or active cancer associated VTE. You can see here the bleeding risk factors that we have to keep in mind. And as I mentioned, provoked and unprovoked, based on the risk stratification, and know what is the risk factor for this development of these VTE events. Duration, as I mentioned, provoked for 3 months, unprovoked indefinite. There are many studies shows that when we are revisit and see whether these patients can be continuous lifelong or it can be stopped and or using like a prevention modality of treatments. There is a new data now about the extended of treatments in terms of the when we start the treatment as a treatment, and we might use the medication like the Pixaban, and we have the studies or evidence for that, or Pixaban and the Pixaban, and these three medications that we can use it in extended therapy or extended therapy for the prophylaxis or prophylaxis. We can use probably the dose can be a little bit different. Here is the example for if you use the Pixaban as the initial treatment, we mentioned for 7 days as 10 milligram, then for during the active treatment 5 milligram BID, usually for 3 months for provoked. And if we extend, there is or we want to prevent of recurrence VTE, 2.5 milligram BID followed completion of 6 months of treatment with Pixaban 5 milligram BID or another oral anticoagulation. Pixaban, again, as I mentioned, 15 milligram BID as the active treatments for 3 weeks, and then you follow for the 20 milligram BID for the ongoing VTE, and also you continue with the prevention of recurrent VTE. The Pixaban bridging with the warfarin for 5 days, and then 150 milligram BID for ongoing treatment and also for preventing recurrent treatments. What guidelines the 2016 and also the new released guidelines in case of the VTE, 3 months is equivalent to 6 months for provoked VTE. Extending anticoagulation is highly effective, particularly in the patients. They need that. And if you compare it with what we used before, the inferior vena cava filter, it is more recommended to use the extended treatment against the inferior vena cava filter. In patients with recurrent VTE on oral anticoagulation, switching to low molecular weight, at least temporary, is recommended. So if we have a patients who are using anticoagulation, oral anticoagulation, and develop recurrent VTE, it's evidence to see that for a temporary time that you get back the patient to low molecular weight heparin, and then you may think about restarting the medication. And usually here in extended treatments and infinitive treatments. VTE without cancer treatment with DOAC instead of warfarin for the first 3 months and beyond is suggested. And unprovoked VTE is associated with higher recurrence risk after discontinuation of anticoagulation, which is greatest during the first 2 years. So if we decide about provoked, at least we need to keep the patient in a safe time more than the 3 months. And it is recommended by the guidelines, at least in the first 2 years. And then we may reconsider that whether to discontinue in some of the situation. And there are some exceptions for that, and because of the time, we don't go through it. One thing that before the end of the talk, that we are using sometimes that we have the patient on these medications, and we call by surgeon that this patient, we need to do that procedure or that operation, and he's on oral anticoagulation. So timing of anticoagulation to stop, usually it depends on the how acute is the procedure or surgery you are going to do. But this is the days before the surgery that you have to think about it. 5 days for warfarin or Pixaban is 1 to 3 days, and the Pixaban 2 to 3 days, and the Pixaban 1 to 2 days. So you see that less time of treatment, of discontinuation for the new DOACs compared with the warfarin. There are some modification. If there is a chronic kidney diseases, you need to consider in case of the DUAC, no discontinuation of 15 milligram dosing, no if 2.5 milligram BID dosing, 3 to 5 days if the eGFR is less than 50 in case of the Dialysis, as it shows in this table. So the summary is, I think we have a good evidence that all DUACs show trend towards fewer thrombotic events, at least non-inferiority to what we used before, namely warfarin. But it is clearly also we have evidence that it is less bleeding than the warfarin. Pixaban is favored in indirect comparison. There is no direct to direct between among these 4 drugs, but if you do indirect comparison, the Pixaban is maybe it's a more safer in terms of the major bleeding and also in some sites of bleeding like GI bleeding. This is in case of the VTE, and as my colleagues also show data on atrial fibrillation as well. No need to routinely bridging for surgical interruption for any DUAC. It's not the case like in warfarin, so we need to bridge with heparin in some of the major surgery or procedures. There is, I didn't mention that, but just we know that there is antidotes for DUACs, whether it is anti-factor 10A or antithrombin 2, and this gives more safety in hands that we could, even if major bleeding happens by these medications, we have the safe weapon which can stop this and avoid this and avoid the mortality or morbidity because of that. So, Mr. Chairman, ladies and gentlemen, my conclusion is that VTE is the common health problem, and they show you data how it's common everywhere, wherever you are, and it's causing morbidity and mortality, and one of the leading preventable cause of death in hospitals. DUACs are important, and it has advanced the treatment of VTA in the last decades or so, and we have 4 medications, at least 3 of them we have it here, if I remember well, it's in the region. And they are effective, these DUACs medications, with better safety than standard care in VTE. The guidelines, the ACCB guidelines recommend DUACs over the VKA in patients with VTE. And a better safety and efficacy ratio will lead to longer duration and also adherence to the medications and less complications and hazard to the patients. Single agents oral therapy without the need of monitoring will simplify therapy and reduce side effects like bleeding. And the risk of recurrence following unprovoked VTE is high. Therefore, extending anticoagulation therapy is highly effective, and we need to reconsider it in some of the patients. Thank you very much.
Thank you very much, Doctor. We now open it for discussions. Can I ask you first, you mentioned that in the extended therapy, you can reduce the Pixaban to 2.5, whilst I noticed the other ones are not reduced. So why is the difference?
The difference is because the study that have been done in these doses, that they are showing that the doses in the 2.5 in Pixaban, in the study, that it shows that it was effective. The other studies that they use that the normal dose or the routine dose in that. There are data on rivaroxaban 10 milligram as well compared with the 20 milligram. But as far as I know, for the dabigatran, it was 150 milligram all over for the preventive or prophylaxis or preventive therapy and extended therapy.
We have a number of questions. One of the common questions here is the use of Pixaban in patients with eGFR of less than 15 and dialysis. It's not indicated, or they don't have the indication here in this part of the world, but you said they have the indication elsewhere. Can you just talk a little bit about that?
I know that there are clinical trials in US in use of the Pixaban in dialysis patients, but this is as far as I know that it is also worked well. We are waiting for this evidence here, and there is no study, and it's off-label. I mean, it's not used in our region, or not labeled to use in the dialysis patients, or because there is no evidence yet to use it here. But there are trials ongoing, and I don't know, Dr. Mu'taz, if you can elaborate more on this, for using it in patients with dialysis, but it is off-labeled in our region here.
So the original studies that looked into these patients with dialysis looked into predominantly pharmacokinetics sort of studies. So they were just taking blood samples from patients and measuring the numbers and comparing them to patients who are not dialyzed, and they showed comparable numbers. So based on that, people have started using it. There have been a lot of retrospective studies that look specifically into this, and all of them are showing results no worse than warfarin, and a lot of the times better than warfarin. Doses of 5 and 2.5 milligrams were tested, and again, the 5 milligrams showed better results in terms of risk of protection of strokes. The 2.5 were safer in terms of bleeding. So it depends on what you value most. As you mentioned, it's not licensed yet in the region to be used in dialysis patients, but in the US we have been using it quite extensively, actually, in Abu Dhabi in dialysis patients. The recommendations in the US is that the dose should not be adjusted. So if you're on dialysis, you get 5 milligrams BID. You reduce the dose based on the other criteria. So if you have somebody who is on dialysis and is above the age of 80, then you would use 2.5. So the renal impairment here counts as one factor, and you need another factor, either weight of less than 60 or age of above 80. So whilst we are still awaiting for the randomized controlled trials, there's now plenty of retrospective data and clinical expertise and experience in using these medications in dialysis patients, and they too appear to be safer than warfarin. If I was on dialysis, I probably would use it. Now that the reversal agents are also available, I think it's probably a no-brainer in terms of using it, I would say. Apparently, when the retrospective studies they were done, it showed that the benefit, which to me is the most devastating side effect, the reductions in intracranial hemorrhages compared to warfarin is maintained in dialysis patients. So a 50% reduction in intracranial hemorrhages.
Yeah, I think you both made very important comments. I think the first thing is that in dialysis, you should be using the 5 milligrams, not the 2.5, unless you have another factor. And we see a lot of inappropriate dosing here of patients. You have to have 2 factors to reduce the dose to 2.5. And as you said, the warfarin really is not that safe in renal failure in dialysis. It's traditionally been used, but there's a lot of data showing that patients don't do much better on warfarin. We have a
to put it in another way, if warfarin just comes into the market now, you do a study with warfarin, there was no way warfarin would pass through this.
Exactly.
We do have options which are better.
There is data that shows that warfarin even causes deterioration in
renal function. Yeah.
When to restart anticoagulation post the GI bleed?
So my knowledge on this, large part of it gets dictated by the gastroenterologist rather than anything else. Now, people have looked into this, restarting it anywhere between 3 days and 2 months. The sweet spot appears to be after about 7 days, which I think what most of the people would do. But it really depends on the level of comfort, whether you know that you've dealt with the cause of this problem. I mean, I restart, let's say, NOACs after implanting a pacemaker 24 to 48 hours after implanting a pacemaker, and I have no problems with that. You can apply the same logic there. Say, okay, I've got a big wound there and it's not bleeding anymore. So if you think that, okay, you had a polyp that you dealt with or an ulcer that you've injected, potentially you could really restart it at like 3 days. But I think most of the people go with 7 days. But ultimately, your gastroenterologist will decide. I don't know if Dr. Abdullah said.
Yeah, can I add, Dr. Mataz? I think it's also, as Dr. Mataz mentioned, it is the decision that take like in a consultation as a group. Gastroenterologists have an important role here because the cause of bleeding is important. For example, if it is a duodenal ulcer, gastric ulcer, the type of ulcer is important. Is there vessels in the base of the ulcer? Then, as Dr. Mataz may delay up to the 7 days. If there is clean base ulcer, for example, that we may get it in 3 days or so. So the decision take individualized based on the patient-to-patient difference in terms of that. But usually within 7 days that you can restart the treatment in most of the cases.
And I also add one point is that often when we stop these NOACs, a lot of people end up putting the patient on low molecular weight heparin or IV heparin, and these are not safer than the NOAC in terms of the risk of bleeding. I mean, for me, I would rather restart somebody's NOAC on the day of the procedure for a pacemaker implant or ablation. I mean, I always do it after ablation, but for a pacemaker implant, I would rather start it on the same day than having to put the patient on IV heparin because the risk of hematoma is significantly higher for me. So each patient, you have to individualize the decision based on the risk of stroke and how high it is, and the risk of bleeding and how high it is, and then you have to pick a point and then decide.
Yeah. During the COVID pandemic, I saw a few patients with DVTs. We weren't sure whether the COVID virus was the cause of the DVT, but I have one patient, for example, he is on a Pixaban. Should this patient be on extended treatment, and can I drop his Pixaban to 2.5 after 6 months?
You mean the COVID patient developed VTE, right? Or to prevent VTE?
He had COVID, and after the COVID, the diagnosis of DVT was made late, a few days later after he recovered.
So nowadays,
it's not clear exactly, but we've seen cases like this.
Yeah. If nowadays COVID is considered as a hypercoagulable conditions. It's a risk factor for VTE. We have just published 2 months ago a meta-analysis which shows this the COVID, and what is the treatment as a prophylaxis is different as a treatment when the patient with COVID developed VTE. He should be treated as a VTE. If you are not sure or you want to prophylaxis and the patient admitted because of the severity of COVID, it is recommended that to start prophylaxis and then therapeutic in the hospital and continue for at least a week or so as outpatient. But this is if no documentation of COVID. And there is a German study which is up to 4 weeks they put the patient in the anticoagulation. But if the diagnosis of VTE made in the post or during the COVID, I don't think that you need to reduce the dose and you need to treat the patients as a VTE and consider the COVID is like travel as a provoked risk factor, like long travel or whatever. There is no data to extend the treatment. As far as I know, I'm aware about data that to extend therapy in a patient with post-COVID, even those who are admitted to the ICU or get a very severe COVID course of disease.
So you would give it just for 6 months?
Yes, as a treatment of the VTE. It's not considered like as a cancer, but it is, it's acute risk factors which happen to the patient. And there's no data to compare, to be honest. And we don't see, COVID is affecting millions of people worldwide, and we don't see a lot of recurrence of the VTE post-COVID. Many of people get COVID, but the incidence of the VTE is the same. But the incidence of VTE post-COVID is much higher especially for those who are hospitalized and the patient, particularly who those need high oxygen or admitted to the ICU.
With regards to cardioversion, which NOAC would you suggest and for how long?
To my knowledge, all of them have had trials which looked into cardioversion with them, and they're all, in my view, as good as warfarin in that respect. How long? The guidelines would say 3 to 4 weeks, so you need to be anticoagulated. Do you TEA them before or not? It really depends. My practice in the UK was that not to TE these patients. So if they've been reliable with taking the medication, I would just go ahead and cardiovert, and that's what the studies were done with. In the Middle East, I think if the CHA2DS2-VASc score is high, I would TE. If the CHA2DS2-VASc score is low, I probably don't. The reason behind that is two things. One of them is that patients here in the Middle East tell you that they've been taking the medications when they're not really taking the medications. And then the second thing is I think AF behaves slightly differently. I mean, I've had patients that I trust that were definitely taking the medications, and I think they're just a little bit more hypercoagulable. I don't know if it is the diabetes. I don't know if it is, metabolic syndrome that they have. But, if I have somebody with a CHA2DS2-VASc of 6 or 7, I tend to TE them these days, which I didn't do when I first started here.
Can a Pixaban be crushed or dissolved for patients who can't swallow?
Yes. So this was actually tested in a pharmacokinetic study, and it showed that there was no difference in the concentrations of the medications. The NHS guidance on this is that yes, it can be crushed, and it can be mixed with apple juice or something like that, but you should be drinking it quickly and not leave it to settle down.
Yeah, I asked our pharmacist this question, and only the Bigatran cannot be used crushed or swallowed. What prophylactic dose of a Pixaban for elective hip or knee replacement?
Maybe Dr. Abdul Nasser?
2.5 milligrams.
2.5.
Yeah. Prophylaxis.
Prophylaxis, yeah. Before surgery.
Yes, I'm not sure about the study in the details, but I think 2.5 that can be used as a prophylaxis.
Mm-hmm. Any indications of the use of NOACs in patients with STEMI and reduced ejection fraction?
I'm not personally aware of that. Maybe you can, Dr. Wael, you probably deal with more MI patients than I do. But I'm not aware of any studies that show any specific benefit in these patients.
There are some case reports where people have used NOACs in patients with LV thrombus, but I personally use warfarin because these are only case reports.
There was a study that looked into these patients, and warfarin, I think, fared better than NOACs. It's one of the few times, apart from metallic valves, where the trend was more towards warfarin than NOACs in these patients. But from what I saw on the question on the WhatsApp, they're saying ejection fraction of 40. It's less likely that you'll have an LV thrombus with an ejection fraction of 40.
I would change the question a little bit because you're not going to have a thrombus. The other group that you shouldn't use NOACs in, which was interesting, was the recent rheumatic fever or rheumatic heart valve, rheumatic mitral valve that was done worldwide, and that showed that warfarin for some reason was better than NOACs. I think they used rivaroxaban in that study. We didn't discuss left atrial appendage, but maybe you want to talk about that a little bit, Mu'taz? Which patients you'd send for
appendage closure?
Yeah.
So left atrial appendage closure has been tested predominantly against warfarin rather than NOACs, purely because most of the studies were done about 10 to 15 years ago. The data shows that overall it's more or less the same risk of bleeding, same risk of stroke as being on warfarin. It will protect you probably from about 90% of the strokes compared to being on anticoagulation. That's where most of the clots sit in the left atrial appendage, but it doesn't protect you from all of them. Initially, people were advocating the use of left atrial appendage as a patient choice. So if you didn't want to take anticoagulation, but so far, all the recommendations from the societies would say you would use it in patients who cannot tolerate, who cannot take anticoagulation, or who have bleeding complications with anticoagulation. So the ones that I have done were patients who had predominantly GI bleeds with anticoagulation, where they were scoped and they had multiple angiodysplasias and like there was no obvious target to treatment there. I'm just about to do a procedure on somebody who quite interestingly, he bleeds into his urinary tract, and then he develops calcium around the clot, and then it ends up sort of obstructing his ureter. So he's had it like he's had the stones removed, and when they send him to histopathology, they found that they're actually clot in the inside. And these just keep on recurring. So this guy, I'm going to do an appendage closure and then stop his anticoagulation afterwards. When you do left atrial appendage closure, it's very important to make sure that you fully occluded the left atrial appendage. If you have leaks, then obviously anything more than probably 0.5 centimeters, your risk is still high in terms of bleeding. So you'll either have to look into coiling or you'll have to look into continuing anticoagulation in these patients.
What's your treatment after closure? You need to use some sort of...
it's very variable. It's not very clear. I tend to continue with the anticoagulation for at least 6 weeks, if possible for 3 months. And then you'll need to put them on an antiplatelet. So, you can do triple therapy for like a short period of time. The minimum you'll need to do is dual antiplatelet therapy for about 6 weeks or so. And beyond the 1 year, they probably need to be on a single antiplatelet, although some people have started omitting that single antiplatelet after 1 year. There's just plenty of protocols on how to do this. But the first, 6 weeks to 3 months, most patients will end up on at least 2 agents. So, either 2 antiplatelets or 1 antiplatelet and an anticoagulant.
Regarding the help replacement and knee replacement, it is 2.5 milligram BID and start 12 to 24 hours after the operation and can be from 10 to 14 days. That's the protocol used.
Mm-hmm. Well, I don't see any more questions, so I'd like to thank you both very much for such elegant talks. And I'd like to thank Pfizer, the Emirates Cardiac Society, and ICOM for this edition of Circulate. And I hope that we will see you for other editions in the future. Thank you very much. Good night.
Thank you very much. Thank you.
Thank you very much, everybody. Have a nice evening.